Hi everyone, welcome to our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here at Phoenix Children's, and today I am joined by Dr. Singh. Thanks for joining us. And today we are talking about micrognathia. It's a condition that's treated in our Division of Plastic Surgery here at Phoenix Children's. So we have a list of questions. We'll run through them. If you have any questions along the way, please feel free to ask them in the comment section, and you will hear Jenny, our behind-the-scenes guru, ask them as they come in. All right, so we will just go ahead and jump right in. What is micrognathia?
So Stacy, thank you first of all for having me. It's my pleasure to be here. Micrognathia is also known as a small lower jaw. It is referred to by several different names. Some people refer to it as mandibular hypoplasia. So the mandible is the lower jaw, and it comes in all varying degrees of presentation. Some can be very severe and others can be quite mild.
Okay, all right. How common is it?
It's hard to pin down a number in the literature, but in general, for micrognathia, it would be 1 in 2,000 live births is the incidence. We don't know what the prevalence is because some of these babies, unfortunately, pass away, and so the prevalence is probably a little bit lower than the incidence of it.
Okay. Are there certain groups of people, ethnicities that are more common to get it than others, or?
No, it's across the board. It's associated with a variety of syndromes, close to 25 different syndromes.
Oh, wow. Okay.
And I'd say half of them are associated with the two of the leading diagnoses are Stickler syndrome and 22q11.2 deletion syndrome.
Okay, so is it always tied to one of those syndromes?
The majority of patients who have the micrognathia are tied. So 50% of the children born with this are tied to those two diagnoses, okay. And the others associated with other syndromes, only about 15 to 20% are isolated without any associated syndromes.
Okay. What are the symptoms, and first of all, how is this diagnosed? Is it diagnosed in utero? If a family knows that their child has one of these other syndromes, can they be tested for micrognathia, or how does that work?
So, screening ultrasounds that are routinely done can pick up on having a smaller lower jaw. Sometimes it's hard based on the baby's positioning. However, if there is suspicion of a small lower jaw, then more detail can be obtained through a fetal MRI, okay. Which Phoenix Children's Hospital does do for congenital anomalies. And I've had probably 2 or 3 patients in the past year where we've been able to detect it in utero and have been very well prepared for the delivery of the baby, as well as the care after birth, because that becomes a big issue with breathing for the babies.
Okay. And I assume if it's not diagnosed in utero, it's diagnosed right after birth.
Right, and okay. it's unfortunately it's a surprise for the family and a surprise for the practitioners. And airway, breathing, feeding become emergency situations at that point.
Okay, and is the main sort of notification of this obvious smaller lower jaw? Do they have to run any tests or anything, or is it sort of just diagnosed on site?
So if you have an in utero diagnosis of a small lower jaw, an ultrasound, and then imaging is done to confirm that, they can offer genetic testing through amniocentesis for the child. Sometimes if they detect other congenital anomalies, for example with 22q11.2 deletion, some of our children have congenital heart disease. And with the micrognathia, 40 to 50% of patients with micrognathia also have a cleft palate. And so those are all detectable conditions on ultrasound and then in greater detail on fetal MRI, and that helps us prepare in taking care of the child after birth. If a child is born with a condition and was not diagnosed in utero, then genetic testing is done after birth, and to check not only for details on the condition of the micrognathia, but to assure that there's no other condition that clinically is not visible to us that we're missing.
Okay. And you mentioned genetic, and it made me think, is this something that can be hereditary? If a family member has it, is the child more likely to have it, and if another sibling has it? same
So
thing?
if it's associated with syndrome, for example, Stickler and 22q,
Mhm.
it is inherited.
Okay.
And if one parent has it, the likelihood of a child having it is 50%.
Okay.
Our genetics colleagues work very closely with us in evaluating the children and the newborns and making sure that appropriate testing is run, and also evaluating other systems that might be involved.
Okay. Other than issues breathing, what other symptoms can families expect for children who have micrognathia?
So if a baby can't breathe well, then the baby can't feed well. And breathing and feeding are the two major concerns for a newborn. Some of our children who are more severe are in the neonatal ICU here, and we monitor them. We do try in a stepwise manner to determine how symptomatic a baby is before we recommend any intervention.
Okay.
So we do monitor the babies closely for a period of time to determine, is this something that we can have the baby accomplish feeding even though they're struggling a little bit with the breathing, or are they just not feeding at all because breathing is so compromised? And what happens is that the lower jaw also maintains the base of the tongue back, and so when a baby's in a supine position and the jaw is small, the tongue base falls back. It's referred to as glossoptosis, and then that leads to the airway obstruction, and then the baby has difficulty breathing and feeding. So those are the two major concerns in the newborn period. Sometimes our children who are mild, they make it out of the hospital, but then they continue to struggle to feed well. Their breathing is okay, but they're struggling to feed, and then they fall into the failure to thrive category. And so those are the children I don't see in the hospital, but I see in my office, referred to me from our pediatric colleagues or from our feeding specialists.
Okay, so there are different severities of this condition. Okay, and so at what point, other than extreme difficulty breathing and feeding, after they're home, say they're released from the hospital, at what point would a PCP say, no, I think you need to be seen for this condition?
So much of the determination of that is based on the parent's description of the baby's breathing and feeding, as well as the clinical evaluation. And I always tell parents, when you're doing a diaper change and the baby's flat on his or her back, are they having difficulty breathing? Are they obstructing? Does it sound like they're not able to clear their airway? And so that's one sign. If they're doing okay with that, when they feed, are they fatiguing quickly? Are they not taking their full feeding? They're falling asleep and they're waking up frequently to feed. If that's not improving, their weight's not advancing, and they have a small lower jaw, then we need to figure out, is it the small lower jaw that's causing these feeding difficulties? So we don't jump to intervene, but we jump to do further evaluation, and that's what should prompt our colleagues to refer for evaluation, is if the children in the small jaw you can see clinically, and then the other symptoms, do they really correlate to the small lower jaw, or is there something else going on that's causing feeding issues? Is it reflux? Is it something to do with a tongue position? And that's where the evaluation process starts.
Okay, great. And can you walk us through that evaluation process and what that looks like, and then what treatment options are available?
Sure. So if a baby's in the neonatal ICU and struggling with breathing, and we oftentimes have babies referred to our NICU specifically for this reason from outside hospitals, and it's a multidisciplinary team evaluation and approach that happens. Typically the neonatologists do our first round of evaluation. If we feel that it's associated with a syndrome, we have genetics involved, genetic testing is sent, and then any midline testing is done, like an echocardiogram, brain ultrasound, anything that could be correlated with this. From an airway standpoint, we observe the baby, check the pulse oximetry, and then both myself and our ENT colleagues with whom the care is coordinated evaluate the baby. Our ENT colleagues are really the experts in evaluating the lower airway, the upper airway, in determining and helping to decide how much of the baby's problem is related just to the jaw. And so we work as a team in figuring this out, and then we decide, do we need to manage this surgically, or can we manage this medically conservatively? And that conservative management is repositioning the baby. So they're not doing great flat on their back, but if you position them on their side, are they able to get the tongue out of the airway and be
Okay.
able to breathe better. If they're able to do that, then can they feed orally, or do we need to put a feeding tube in them?
Okay.
And if a feeding tube needs to go in, how long do you keep it in before you say we need to do something surgically? So some of the babies have growth of the lower jaw, other babies do not. If they're associated with syndromes, they tend to have less growth of the jaw with age,
Okay.
as opposed to the children who have no associated syndrome. Those children tend to fare best with growth of the lower jaw. But it still takes years for the jaw to grow, and it's not the expectation that in 1 month or 2 months that the baby's jaw will be of a normal dimension and they'll be able to have no feeding or breathing issues. So it's a longer process.
Okay.
And so if the severity of the jaw is there, we tend to intervene surgically.
Okay. And at what point, not necessarily age, but at what point would you say, is sooner better when you have to intervene because of the growing bones, or?
So we do look at the baby's overall health,
Okay.
and other conditions would take priority. If the baby has congenital heart disease that really needs to be addressed, and putting them under anesthesia, the risk is too high. So we take into consideration everything, but say the baby does not have any other known congenital conditions, then we're really looking for the baby to be full term. I like for our babies to be at least 8 pounds before we operate, just to have them go through the surgery. And that gives us also some time to observe the baby to see if conservative management is going to work for our baby while they're in the neonatal ICU.
Okay. And if they don't have the surgery when they're a baby, is there any other point where they can have it, or is it?
They can have it when they're older. So
Okay.
if they make it through the first year of life and they're not struggling with breathing or feeding, but they have a small lower jaw, it then becomes more of an elective surgery of when do we correct the jaw deficiency if it has not grown. And I typically would wait until they have gone through childhood and teeth have erupted to determine if they really need it.
Okay.
But I think that our real focus in evaluating these children in a multidisciplinary, interdisciplinary time point is in the newborn period, because that's when our families and our babies tend to struggle the most.
Okay.
Some of our babies make it home from outside NICUs and they have not seen specialists, and I think those are the babies that concern me the most, because we'll get a call from parents saying, my baby's got a cleft palate, not gaining weight. I see them in my office and they've got a small lower jaw. Not only are they not gaining weight, but they're struggling with breathing as well. And those are the ones for me, I worry about. They have no monitors at home to see what their oxygenation is. And I worry about their airway, if they're going to get blocked and have an emergency at home. And that's where we really push to get our ENT colleagues, our feeding team involved to see where is the concern. The neonatal ICU is a safe haven in that we can monitor, and if there's an emergency, we can address it. But I feel our babies who are at home with this condition, for them it's more critical. And so if we send a baby home without any surgical intervention and we're just doing medical management, we always make sure that they have a monitor to check their oxygenation level that alarms, so that if the parents are outside the baby's room, they know, and they're not constantly having to watch the baby even when he or she's asleep.
Okay, and for those babies who aren't from our NICU who left, parents again should be aware of the difficulty breathing when babies are on their stomach. Is that
on their back?
On their back. Okay.
They do better on their stomach because the tongue tends to fall
Lean
forward.
Okay.
Right.
Okay, so on their back. Anything else that they should?
And feeding challenges where they're having trouble feeding, they're fatiguing, they're kind of gasping for a breath while they're trying to feed.
Okay.
And cleft palate is associated with approximately 50% of our babies who have micrognathia.
Okay, all right. And can you walk us through what the surgical process looks like if that is the route that is needed for the baby?
Sure. So, there are 2 different surgical procedures that can happen. One is what I consider an old-fashioned surgical procedure, and then the other one is kind of modern-era surgical procedure. The old-fashioned procedure is considered or termed a tongue-lip adhesion, and it's been done for several decades. The tongue base is sutured surgically to the lower lip, and what that does is it just holds the tongue out of the airway.
Okay.
So that when a baby is positioned on the back or is feeding, the tongue does not fall back.
Okay.
That is a soft tissue procedure only. It's very low complications, very low risk, and it's done in the newborn period in the first few weeks of life. But the downsides to that are that it doesn't normalize the baby's jaw anatomy. The jaw still remains small, the tongue still remains posterior, and feeding actually becomes more difficult oftentimes because the tongue doesn't have the natural movement that a tongue would have because it's adhesed anteriorly. Some kids are able to do well with feeding, with a lot of feeding therapy after that, and they do have jaw growth. And the reason that is a procedure that's been done for many decades, and some centers still continue to do it, is because they feel that ultimately the baby's jaw will grow and the baby will have better relations of the jaw, and we can hopefully avoid a big surgery for them. But we know in the short term that in the first year, year and a half of life, until the jaw starts catching up a little bit more, that the babies struggle. They continue to struggle with some breathing. They continue to struggle with feeding. And so the surgery that's done now most commonly in centers is what's called mandibular jaw distraction. And there's small incisions that are made just underneath the jaw at both angles. And there's a little cut that's made in the bone behind where the teeth are. And there's a small device made of titanium called a distractor that's placed. It's buried underneath the skin, but there's a small arm that exits here. And it's done on each side. Each day, the device is turned 3 times, so it equals 1 millimeter a day, and the jaw slowly is moved forward. And that takes typically about 12 to 15 days. And we usually keep our babies in the neonatal ICU during that period of time, because until the jaw comes forward, breathing is still uncomfortable, and we still have to monitor the baby. Sometimes after just 5 or 6 millimeters of movement, all of a sudden the babies are breathing better and feeling better. And so that we do send the babies then home, and the parents can continue turning the devices at home. And so then those devices, say they're activated for 10 days. We then let the bone heal for 20 days and then remove the device. So usually about a month, month and a half, they do need a second surgery to remove those 2 devices. But the data and the studies that have been done nationally show that performing the mandibular distraction on our children with micrognathia leads to improved feeding within 2 weeks of the surgery and improved breathing, so that they can go home with no monitors and no feeding tubes, eating solely by mouth. And it allows us to then repair the palate on time. If we do the tongue lip adhesion in the jaw, we're waiting and waiting and waiting for the jaw to grow. We're still worried about the baby's airway, and closing the palate at your usual age often gets delayed because the jaw still hasn't caught up in growth.
Go ahead.
No, and so it just keeps the subsequent surgery that the baby may need within the recommended time frame. Right.
And so will the jaw grow on its own if you have that second option that you mentioned?
If we do the surgery? So the jaw does continue to grow. Some babies do need further jaw surgery. And it just depends on what the underlying syndrome is and what the underlying anatomy and severity of the jaw is. I've had babies where I've done the mandibular distraction, and I continue to follow them out. They're 14, 15, 16 years old now, and they don't need any more surgery. And then I've had other babies where we've done the surgery, same advancement, same device, and their growth pattern is just different, and they're tending to grow in a pattern where I feel like they would benefit from another jaw surgery. But we usually wait until that second jaw surgery until they're skeletally grown. So until they've had all their teeth come in, they've had braces, and then we do a final jaw surgery. Some of them only need the chin to be advanced, that the jaw is in good position. So each child's anatomy is a little different.
Great. Tell us about our Division of Plastic Surgery here at Phoenix Children's. We're about a year old, right?
Correct. We're a year old.
You've been here working with us, though, for many years.
Right. So we're a year old here at PCMG, but we have been in the community for many, many years, and we are affiliated and closely work with the Barrow, Cleft, and Craniofacial Center, and our feeding specialists are experts in helping babies with micrognathia and cleft palates. And we team all of our children. Dr. Nate Page, who's the division head of ENT here, is also on our craniofacial team. Dr. Teresa Grebe, who is the interim chief of genetics, is also on our craniofacial team. Dr. Mark Salovitz in ophthalmology. So closely together to really take care of all of our babies with cleft and craniofacial conditions. We're happy to be here based at PCH so we can really continue the collaboration closely. It's always nice when parents can come and be seen in one location by a lot of specialists on the same day.
Definitely. It helps having access to all those different specialists, especially when it's a genetic or a condition or a syndrome, as you pointed out.
And I think it promotes coordination of care, being able to speak with one another, discuss the child's care, and then really make recommendations for the family. And our ENT colleagues are in the same office space as we are, so we're able to often see our babies on the same day.
Okay, that's great.
Yeah.
Very exciting for Phoenix Children's to have you guys on board, and ENT and ophthalmology all fairly new as well to Phoenix Children's. So perfect. Is there anything else that we didn't talk about that you wanted to touch on about Micrognathia?
I guess just a final couple of comments in that some of our children with Micrognathia who have syndromes, they are not candidates for jaw distraction or tongue lip adhesion because of the anatomy. So some of our babies with hemifacial microsomia, Goldenhar syndrome, where one of the mandible, it's so small, there's not enough bone to bring forward. Okay. And so a small percentage of our babies, despite all of our efforts to help them heal and help the jaw grow, do require tracheostomy. And that's also where our ENT colleagues come in to participate in the decision-making process with us as to what is the best course to make sure that the baby's airway is safe. And because we know that we'll be able to reconstruct the jaw when they're older, it's just not a possibility when they're this small. Okay. And so those babies, there is no solution in the newborn period, but it's a small percentage of babies.
Okay, and just find the best way to take care of them, right? With what we can. All right. Well, if you have any questions after we air, please feel free to leave them in the comment section, and we'll make sure Dr. Singh gets them. Thank you for joining us. Thank you for being here with us today.
Thank you.
And be sure to tune into our Facebook page for upcoming Facebook Lives. Thanks for joining us.